I've mentioned ways to modify standard of care, so I just want to say a little bit about that. So uh, radiotherapy is part of standard of care, and there is the sort of the standard regimen of radiotherapy, 60 gray, given in fractions of 2 gray over a course of about 6 weeks. This is just an example of studies where they looked at pretty much about half the dose. So for example, if you're looking at an elderly patient who may not tolerate that much radiotherapy, we have data that shows that if you basically cut that in half, you can still get some benefit. If you have to shorten the radiotherapy, but if you can continue to add temozolomide, there's benefit there. So again, here's an example of a survival curve looking at a patient population where they had to do a shortened course of radiotherapy. They added temozolomide, and those patients continue to do better. And here's the radiation dose that they used, and you can see that that's much less than that standard of care therapy I just showed you. I'm going to move a little bit quicker to make sure we wrap up in time, and hopefully I can get to some of your questions. Another thing to keep in mind is MGMT status. So I haven't mentioned that before, but that's now a universal marker that we do on all of our patients to look for. So to remind you, MGMT is a DNA repair enzyme. And if that is shut down by promoter methylation, then that tumor cell is more vulnerable to things that's going to mess up its DNA, like chemotherapy. And so it's not going to be able to repair itself. So we know that in patients who have MGMT promoter methylation, so it's not being expressed, if you give them temozolomide, their survival curve is better than those who have MGMT that's not methylated. So in a nutshell, if patients cannot tolerate standard of care, and if you get that MGMT status, if it's methylated, they probably will do better temozolomide. If it's unmethylated and you can't do both things, then you probably should focus on radiotherapy. So there are other FDA-approved options out there. This is not a comprehensive list, but here are some examples. These are not part of standard of care again, but they have been approved for various reasons. So for example, there's this picture in the top right shows these carmustine impregnated wafers that you place into the resection cavity. So these wafers have this non-specific chemotherapy. Think of like temozolomide, which is also non-specific chemotherapy, is in these wafers, and that will leach out into the surrounding resection cavity. It's a terrific theory because we know that when these tumors progress, the majority progress adjacent to the resection cavity. So this local regional therapy makes sense. There is very robust data that's years old now showing that this has some clinical benefit, but it hasn't really caught on. And I've just listed a few examples of why. Very costly. It's a little bit toxic to handle. There's significant side effects. It can make the brain react nearby and swell, and so it can be difficult to manage patients who get that. Everybody's probably heard of bevacizumab, the anti-VEGF antibody. So that was approved a bit early based on some early results, but subsequent randomized clinical trials showed that it really was not efficacious. However, big however here, it clearly is used a lot nowadays because it does play a role. It can help with things like symptomatic radiation necrosis and edema. A more recent example are tumor treating fields. So these are cap-like things that are placed on patients that deliver this low intensity intermediate frequency. And it appears to have sort of an anti-mitotic effect. There are a few other agents that I won't go into. And just to illustrate that data from the tumor treating fields therapy. So this just recently came out not long ago. And you can see in older patients, those folks have a better survival curve who got it. And even in patients who have MGMT promoter methylation, who also get temozolomide, they show an additional benefit if they got the tumor treatment fields. So there's a lot of folks out there arguing that this should become part of standard of care. Um, I think we probably need a little bit more time with that therapy. All right, so there are lots of emerging targets out there for the glioma subtypes. This is not a comprehensive list, but you can see subtypes here. You can see associated genomic mutations that have been discovered. And there are very specific therapies out there that can be tried. So this is kind of an area that I find very exciting. So here's an example of a recent study, just came out earlier this year, where they used molecular profiling-based decision-making to decide on a targeted therapy in their GBM patients. So they identified these mutations, they pulled very specific drugs off the shelf that target those mutations, and then they use that strategy to treat their patients after they got standard of care, of course. Their conclusion said that overall survival was similar with or without this molecular guided treatment. So I would say more work needs to be done. But here's a very exciting piece of data from that work. So if you just look at the patients who have MGMT unmethylated tumors, so again, those patients will not do as well with temozolomide. But if you gave them a targeted therapy, the red line, in this study, they had what looked like a very promising survival curve. So there's certainly something there, and there's a lot more work that needs to be done on molecularly guided treatments. We're just now getting into that. This is about my last slide. So there's numerous other ideas out there that have been studied for years. They're still being studied, and you can see the variety, incredibly diverse areas of study in how to treat these tumors. And I mean, if you're looking for an area of research to get into, you could just stand back and throw a dart at this slide. And I promise you, no matter where it lands, you'll find a very exciting area of study to get into.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.